Good afternoon. Welcome to the Foundation for Opioid Response Efforts webinar series on maintaining access to opioid use disorder treatment and recovery services during the COVID pandemic. I'm Karen Scott. I'm president of the Foundation for Opioid Response Efforts, or FORE. And FORE is a national private foundation that is focused on supporting solutions to the opioid crisis. Over the past several months, we've developed this series of webinars to highlight the immediate challenges to maintaining access to OUD treatment during the pandemic and highlight some of the practical experiences and solutions rapidly evolving around the country. For communities of color, the pandemic presents one additional set of barriers to OUD treatment. And so today we are turning our focus to the intersecting issues of racial health disparities, OUD crisis, and the pandemic. Today you will hear from an incredible panel of presenters focused on identifying those disparities in access to treatment for OUD, as well as examples of specific programs in the community, one focused on syringe services programs and one on a community-centered approach. That will be followed by comments and remarks by one of our board members, Dr. Westley Clark, and then our question and answer session. Please note that we are extending the discussion time on the Q&A session today, so this webinar will run until 4:15 rather than 4 o'clock due to the large interest and big audience that we have today. So first, a moment on our logistics. As always, the webinar is being recorded and will be available on our website shortly after this session ends. We will also make this presentation available for download on our website. We really encourage people to participate and ask questions and engage with our panel of presenters this afternoon. Please use the Q&A button found at the bottom of your Zoom screen. Also note that if you have a similar question to one that's been entered, you can upvote that question using the thumbs up button on the question. We'll read as many of the questions as live as time permits. We will also develop a Q&A document following the webinar based on questions that were submitted. So that's our way of trying to get to additional questions following the session. In addition to the questions, if there are resources that you would like to share with us and share with this audience, please send them to us at info@forefdn.org. And finally, there is a brief survey that allows us to get feedback on the webinars immediately following the close of the webinar. Please do take a moment and complete that for us. It really helps us in our planning and knowing where we can best use our resources to contribute. Thank you. So to that end, I'll just highlight again that the foundation has been responding to the pandemic through convenings such as these, through developing resources on our website, and as well as our grant making. And we continue to expand each of those streams of work. Following today's webinar, our next webinar is planned for 2 weeks from today, and it will focus on some early preliminary findings from work we're supporting to look at how opioid treatment programs are responding to changes and relaxations in the telehealth regulations and what their capacities are to rapidly pivot to telehealth modalities. Again, our prior webinars are recorded as well and available through our website. We encourage you as well to sign up for our newsletter and follow updates on our website for further information about activities such as the webinars, as well as announcements about RFPs. Great. So today I am absolutely thrilled to turn to our presenters. Dr. Helena Hansen is an associate professor in the departments of Anthropology and Psychiatry at New York University. Dr. Hansel Tookes assistant professor of clinical medicine at the University of Miami Miller School of Medicine, and founder and medical director of the IDEA Exchange Syringe Services Program. Dr. Morgan Medlock is Chief Medical Officer and Director of Crisis and Emergency Services for the District of Columbia Department of Behavioral Health, and an assistant professor at the Howard University College of Medicine. And then, as I noted, following the three presentations, we will have special commentary by Dr. Westley Clark, who is a member of the FORE Board of Directors. Dr. Clark is a professor at Santa Clara University in California and is a former director of the addiction treatment program for SAMHSA. Let me turn now to invite our first speaker, Dr. Helena Hansen, to lead us off. Thank you.
Thank you so much, Dr. Scott. I want the first slide up, please, if possible. Okay. So this may be a headline, an article that's familiar to many of you. And I just want to start off with the point that the perceived whiteness of our opioid crisis has made invisible the ways that the crisis is produced by a form of structural racism, which kills both whites and non-whites. One that uses images of whiteness to get around regulations of claims to safety and targeted marketing. Next slide, please. One that's made invisible Black men who currently have the fastest rising rate of lethal overdose from opioids, while whites are 3 to 4 times as likely to get offered buprenorphine. Next slide, please. And next slide, please. And next slide, please. So they're 3 to 4 times as likely to get offered buprenorphine for opioid use disorder than Blacks. And whiteness is central to our commodified biotech and healthcare industries. Their use of racial hierarchies to segment and open markets. It involves the mutual racialization of drugs and people. So for example, we know that illegal drugs in the US have long been linked to Black and brown people. Next slide, please. And next slide. And next slide. But also drugs can be white, as in targeted to white people. Next slide. For example, the 1940s to 70s barbiturates and benzodiazepine marketing ploy to suburban mother's little helper. So whiteness can pharmaceutically enhance the whiteness. So actually drugs can pharmaceutically enhance the whiteness of people whose privilege is in question because of the stigmatizing diagnoses like addiction. And that's the topic of our conversation today. In the case of the divergent racial identities of methadone and buprenorphine as medications for opioid use disorder, next slide please. We have to remember that methadone was introduced as Nixon's first weapon in the war on drugs. In the midst of race riots and white flight from cities, with the nightly news highlighting heroin as a Black problem of crime. So contrast this with the context of buprenorphine's FDA approval, next slide please. In the midst of media and congressional concern about suburban prescription opioid use and buprenorphine's exclusive marketing, next slide, to white middle-class consumers. So today I'll give you an analysis from my forthcoming book on the US opioid crisis in terms of what I call technologies of whiteness. Next slide, please. That is social technologies of neuroscientific metaphors, policy and industry strategies that maintain racial boundaries around biomedical uses of opioids. And this scheme is informed by whiteness studies. It's an offshoot of critical race theory, and it predicts that, 1, whiteness is a category of exclusion, and therefore requires cultural and political maintenance of its boundaries. 2, white race is unmarked as the assumed norm in the US. Up until recently, it was rarely explicitly named, either in public policies or in the media. And then 3rd, whiteness is defined by its other. White and Black, or non-white, are interdependent. Punitive American drug policy has long had a mutually defining twin of legal narcotics for whites who've had access to personal doctors, starting with morphine and over-the-counter heroin for Victorian middle-class housewives, then moving to post-World War II suburban use of barbiturates, stimulant diet pills, and Valium, and now back to prescription opioid pain relievers. And then fourth, white privilege has its costs. Not only do consumers pay inflated prices for patented prescription opioids, they pay with their lives and overdose by lethal substances to which they have quote unquote privileged access. So next slide, please. The 4 technologies of whiteness that I've identified in my research are addiction neuroscience, new biotechnologies, regulation, and marketing. Next slide, please. I'll start with the least visible technology of race making, and that's brain science. Next slide. Let's place opioid development on the backdrop of President Bush I's decade of the brain. This was an era in which NIDA was directed to look for neuromolecular bases for addiction in anticipation of breakthroughs from the Human Genome Project. And in the process, next slide, NIDA renamed addiction a quote unquote chronic relapsing brain disease. The scientists involved had a social justice intent. They wanted to destigmatize addiction by demonstrating it's a legitimate biological condition rooted in molecular action at neuroreceptors, not a problem of morality or choice. So next slide, please. Brain images like this, by taking the subject and his or her trappings of gender, race, and class out of the picture, and by taking the offending organ out of the body altogether, convey a universal condition unmarked by social identity. What the scientists did not anticipate was that scientific universalism, because it implied a standard white male subject, would help open white markets to new opioids, and that the unequal ways that biotechnologies are disseminated would enhance the social stratification of addiction. Next slide. So next technology of whiteness is new biotechnologies. Building on the neuroscientists' ideology of technological solutions to addiction, in '96, Purdue Pharma got FDA approval for OxyContin as a quote-unquote minimally addictive pain reliever suitable for chronic management of moderate pain. And this was based on its patented sustained release capsule technology, which in theory lowered the reward for users by preventing an initial rush. So drug marketers advised new opioid prescribers to direct OxyContin to quote-unquote trustworthy patients, which among American physicians whose studies have shown suspect non-white patients of drug abuse implied white patients. And of course, what the model of addiction-proof biotechnology left out was the social inventiveness of drug use. OxyContin users interested in a rush quickly learned to crush and snort or inject the oxycodone in each capsule. Another biotechnology developed specifically in response to the white, suburban, and rural prescription opioid epidemic, next slide, is the opioid buprenorphine, which was legalized for maintenance treatment by prescription by private doctors, unlike methadone, which is dispensed daily in highly regulated clinics. And I ask you to bear in mind the racial imagery of methadone, its birthplace in 1971 as the first weapon in the war on drugs. The next slide, please. The third technology of whiteness, regulation. The Drug Addiction Treatment Act data that was passed by Congress in 2000 enabled any certified physician to prescribe Suboxone in the privacy of their own offices, unlike methadone, which was restricted to specialized clinics. In congressional debates leading to the passage of data to 2000, there's a clear emphasis on a new kind of drug user, one that is quote unquote young, suburban, and not hardcore, end quote. That's implicitly white. Recorded testimony from federal officials stressed that buprenorphine was uniquely appropriate for a new kind of opioid user as opposed to methadone, quote, which tends to concentrate in urban areas and is a poor fit for the suburban spread of narcotic addiction. So with this racially coded language in which suburban and new kind of addict referred to middle-class whites, Data 2000 passed Congress and reversed 80 years of federal prohibition of private physician opioid maintenance for opioid dependence. So Data 2000 kept the restrictive methadone system intact and did nothing to alter the drug laws that mandated inner city heroin users to prison, but it did create a new treatment track for those with the resources to take advantage of it. To give additional assurance to the DEA that buprenorphine would not spill over into illicit, implicitly Black and brown markets, buprenorphine's manufacturer, along with the Federal Substance Abuse and Mental Health Services Administration, developed an 8-hour certification course that was required for doctors to prescribe buprenorphine, the first and only prescription drug in the US to come with such a requirement. In a race and class stratified healthcare system, such as we have in the US, where access to general doctors is often limited to those who can pay, patented expensive technologies for private office delivery in themselves encode white race and middle class. Also, public sector doctors tell me that the certification requirement is a major barrier to making buprenorphine available to low-income people, as public clinics do not provide time or incentives to pursue certification, while prescribers in the private sector can charge fees of up to $1,000 for an initial visit for buprenorphine induction. Next slide. So the fourth, technology of whiteness, ethnic marketing. In 1996, the FDA accepted OxyContin's manufacturer's claim, Purdue Pharma's claim, that it posed less than a 1% risk of addiction, enabling Purdue to open an opioid market that had previously been restricted to those with severe acute pain, like post-surgical or cancer pain. Open that market to a new, much larger market of patients with moderate chronic pain, like lower back pain, who go to primary care physicians rather than specialists. So the company hired almost 700 drug reps who canvassed a call list of nearly 100,000 physicians in the first few years. Purdue targeted generalists in white suburban and rural areas, serving patients that the public and the DEA did not think of as at high risk for addiction or drug trade. Purdue's strategy was successful. It led to a 10-fold increase in prescription opioids nationally, with disproportionate uptake of OxyContin by prescribers in white suburban and rural areas of states like Maine, Ohio, Kentucky, and West Virginia. So in a newspaper content analysis that I completed, next slide, I found that in contrast to articles about the criminality of Black and Latino drug users, suburbanites addicted to OxyContin were portrayed sympathetically in the media as victims of overprescription or as people struggling with real or existential pain. And after the government imposed restrictions on opioid prescribing, many of these suburbanites turned to heroin, leading to a whitening of media coverage of heroin. Next slide. Heroin users who had long been portrayed as Black or brown. Next slide. The targeted intervention for these new heroin users, buprenorphine, otherwise known as Suboxone, was marketed to middle-class insured patients over the internet. Next slide. Manufacturer-sponsored web-based public service announcements featured white professionals and business owners on Suboxone maintenance. So looking at this, this image from a website sponsored by the manufacturer of buprenorphine, and I invite you to read its visual racial coding. This website features a link to a Suboxone prescriber locator service created by the Federal Substance Abuse and Mental Health Services Administration. So browsers enter their zip code to generate a list of Suboxone prescribers, most of them in private practice. So these strategies created an exclusive yet lucrative segment of the market for Suboxone, making it a blockbuster drug at over $1.5 billion a year in US sales by 2012, second only to OxyContin, which reported US sales of $3 billion in the same year. Next slide. So to conclude, racial capitalism, that is, profit-making strategies based on racial hierarchies and symbolism, is a primary driver of biotech and pharma industries in the US. New technologies are pitched to an affluent white clientele that can pay for patented products, which open markets for products that trickle down to non-whites as patents expire. And then two, the magic bullet ideology that new, expensive, patented technologies can solve a complex biosocial problem like addiction in themselves propagates structural racism that is harmful to whites and people of color alike because it erases the social structural causes of addiction as referenced by the concept of deaths of despair. And then lastly, public resources must be moved from drug development of magic bullets toward innovative, biosocial, community-based treatment approaches that you are about to hear about from my co-presenters. These are approaches that necessarily integrate medications with recovery networks of support, harm reduction, and social services delivered by trusted community members and peers. And nowadays, with 30 out of 50 US states reporting increases in overdose deaths since COVID, the toxic intersection of opioid use disorder with COVID is making this extremely urgent. Just look at the current COVID containment failures in our country based on profit motives, hoarding of tests and supplies, and the feeling among whites that it is possible to use technologies, including forthcoming vaccinations, to insulate themselves from Black and Brown people who suffered first in the epidemic. And now I'm going to leave it to my co-presenters to illustrate what these innovative community-based biosocial treatment approaches look like. So you'll next hear from Hansel Tookes, who's Assistant Professor of Clinical Medicine at the University of Miami and founder and Medical Director of IDEA Exchange SSP. Thank you.
Thank you so much, Helena. That was just incredible. And I feel a little bit set up going after you, but you did sort of, you set me up because here I am presenting from Miami, Florida, which is now the capital of the coronavirus pandemic with unmitigated spread. And I'm going to present to you what we are doing in our response to the coronavirus pandemic here in South Florida, where there is a huge lack of leadership in this arena. Next slide, please. And I do also want to say it's the IDEA Exchange, actually. So we named that after the Infectious Disease Elimination Act, Syringe Services Program. The reason that we called it IDEA was because everybody was calling our legislation the needle bill, and we wanted to rebrand it. But unfortunately, the name of our Syringe Services Program has DEA in it, so that was unfortunate. But back to the topic at hand. So coronavirus here in South Florida. So this was an article from back in April, and this was in the New York Times, and it said, everybody wants an antibody test. Everybody on this private island can get one. So this is Fisher Island, which has a very small population. The Black population is Oprah Winfrey. And on this island, they were able to, at the beginning of the pandemic, obtain coronavirus tests for every single person who lived there and every single person who worked there. And this was at a time when there were limitations on coronavirus testing nationwide, as there continue to be huge problems in testing and turnaround times. But on this private island, everybody had access to testing as they tried to isolate themselves from the global pandemic. Next slide, please. However, this is a very different view. This is the population of Miami-Dade County jails. And so I was actually asked to do inspections of the Miami County jails to make recommendations on how they could mitigate the spread of coronavirus. And you can see here in this picture, we have a largely Black and Brown population, which is how we see incarcerated individuals nationwide, unfortunately. And there was no possible way in these dormitory style jail cells to socially distance or practice any sort of mitigation for coronavirus. So quite obviously, my recommendation was that they should decarcerate the individuals who were in the jail in order to mitigate the spread. And this recommendation came right before there were major COVID outbreaks in all of our corrections institutions in Miami. But it's just very interesting to look at the juxtaposition of Fisher Island, where everybody got a test, to the jail where there was no access to tests and no means to prevent the spread of coronavirus, largely because of the demographics of the people who are incarcerated in Miami, the vast majority of whom are there for substance use disorder related offenses. Next slide, please. And a lot of you saw this as well on the upper left corner. This is Dr. Armin Henderson. This is one of my colleagues at the University of Miami, a courageous hospitalist who's working nights on COVID wards right now at University of Miami Hospital. And during the day, he takes his white van around and helps to do coronavirus testing and bring services to people who are experiencing homelessness. And he ruffled some feathers early in the epidemic here. And for that, he was accosted by the Miami Police Department. This came just weeks before the murder of George Floyd on Memorial Day. And you can see on the bottom right, that's me after rounds at our public teaching hospital, Jackson Memorial Hospital here in Miami, Florida. And we are kneeling for 8 minutes and 46 seconds. This was a very challenging time as a Black male physician. I have to say that the fact that I was on our inpatient HIV teaching service at Jackson Memorial, it was a godsend, because I was able to really focus my efforts on taking care of those patients and didn't devolve into a situation of despair, which was what many of us felt during that time and continue to feel throughout the coronavirus pandemic. Next slide, please. So there are some good things that are happening here in Miami. Immediately after the pandemic, my students at the university have a Thursday night free clinic, a wound care clinic for people who inject drugs. We do a lot of incision and drainage, and we do a lot of antibiotics. The students were removed from their clinical duties back in March, and they came to me and said, how can we continue to serve our community? And very quickly, they pivoted to a telehealth approach to get people prescriptions for buprenorphine. This was a fantastic idea and really encompassed what is my vision and my research program for bringing healthcare for people who are overly stigmatized by the healthcare system, including people who inject drugs and people with opioid use disorder. I really feel that we need to bring healthcare out of the healthcare system, the traditional healthcare system, and bring it to the patients. That's the only way to end the HIV epidemic. That's the only way to bring low barrier access to medications for opioid use disorder to them. So we're very, very excited to get this going, and we set up a website where people could sign up to access our prescriptions for buprenorphine. Next slide, please. And so this can show you the first 2 months of our program. We had 31 people request appointments, and we were able to evaluate 22 of them. 15 of them were prescribed buprenorphine, and 12 were able to get those prescriptions dispensed. The average time from the appointment request to the dispensing of the buprenorphine was 9.5 days, but through continuous process improvement, we were able to decrease those times to access the medication, and also find ways that we could eliminate cost, and which is a major barrier for the prescription of buprenorphine using 340B pharmacies. The reason that it's so difficult to prescribe buprenorphine normally is that there are really onerous prior authorization requirements for the dispensing of buprenorphine. It requires a urine drug screen. It requires a signed contract that says that you're going to adhere to the treatment and not give anybody your strips. It requires all of these things that are just part of the carceral punitive approach that permeates our entire healthcare system in the approach to substance use disorder. Luckily, during the coronavirus pandemic, some of those things changed. Next slide, please. So we were able to do these on-demand or scheduled appointments. And so my team at the Syringe Services Program were able to go out to people and meet them where they are, because we wanted to address the digital divide. You know, a lot of people could sign up for their appointments online and things like that, but we wanted to make these services available to people who might not have access to the ready access to the internet. So my team would go out with the iPad to somebody's house or under a bridge, and we were able to do a Zoom meeting, send the controlled substances electronically, and actually deliver the medications directly to the patient. And this is really important because it allowed people to remain in their homes in shelter in place during the pandemic. But a lot of these people weren't accessing the traditional healthcare system anyway. So it allowed us to have a new opportunity to offer these life-saving medications to them. Next slide, please. And luckily, the Drug Enforcement Agency did loosen the requirements for conducting these visits. We actually did not have to do face-to-face for the first prescription. We could use telehealth via Zoom or FaceTime or even just telephone. It was really amazing. And what I really want to emphasize is that all of the progress that we've made during the pandemic, removing these man-made barriers to getting buprenorphine, must remain in place afterwards. You know, it greatly accelerated, COVID greatly accelerated the use of telehealth. It greatly accelerated or increased access to buprenorphine, but I already see the barriers coming back, and we cannot allow these, all of the progress that we've made to revert back to the system where people do not have access to these life-saving drugs. Next slide, please. you can see here on March 20th, we requested that the Agency for Healthcare Administration in Florida waive the urine drug screen requirement because we were getting a lot of Medicaid requests, prior authorizations denied because we didn't have urine drug screens when we were doing the telehealth encounters. They were able to grant us that, but they still required, as you can see by the form that our pharmacists are always filling out below, you have to put in the dates of their psychological counseling sessions and the method that they're going to do it. And you have to include the urine drug screen results if you have them. All of these requirements for accessing the drug are like nothing else, no other medication that I know. And as we've removed these requirements to accessing Medicaid, which is largely Black and brown populations who have Florida Medicaid, we have to make sure that moving forward, we don't reinstitute all of these barriers. Next slide, please. The National Academy of Sciences released this report this year, Opportunities to Improve Opioid Use Disorder and Infectious Disease Services. It really called to X the X waiver so that you don't have to do the course to prescribe buprenorphine. Even though I'm a buprenorphine instructor, I think that that is definitely the way that we should be going. But it also called for the removal of all of these onerous prior authorization requirements. One insurance company during COVID denied my patient who was pregnant buprenorphine because they didn't have a physical signature on her treatment agreement, even though I noted in the chart that she had verbally consented to her treatment. So we really need to move past all of this, this carceral and punitive approach to the treatment of opioid use disorder. Next slide, please. But here we are at the peak of our pandemic here in Miami, and people are dying of COVID daily in the state of Florida now. But we have to remember that people are still dying from overdose. We all got that alert from the New York Times yesterday with quotes from all of the experts in the field showing that overdose deaths are really the silent epidemic that is going to be very salient when we look back on the year 2020. So this is us at the Idea Exchange on Saturday, celebrating the life of somebody who overdosed and died at our program. And this van has a memorial to the people that we've lost, but this van is very important in bridging our disparities at Idea. There's so much distrust of the medical system among our minority communities that at our storefront needle exchange in the health district, we were seeing mostly the people that Helena was talking about, the white suburbanites who were driving in, but the van for our program does the work. It goes into the community, it brings buprenorphine to the people, it brings access to life-saving syringe services to the people, and we are just forging forward here in Miami. But when we come out of all of this, when we pass the COVID pandemic, and when we come out of all of this racial unrest that we've had in the wake of the murder of George Floyd, all of us need to continue to do the work and make sure that we don't lose the progress that we've made. Next slide, please. This is just a thank you to everybody on my team and my career mentor, Lisa Rosenmetch. And a participant of the Idea Exchange made this for me when he was hospitalized in the hospital, and it says, making it a little safer in an impossible lifestyle. Next slide, please. So next, we all have the pleasure of Dr. Morgan Medlock, who is Chief Medical Officer and Director of Crisis and Emergency Services for the District of Columbia, and she is Assistant Professor of Psychiatry and Behavioral Services at Howard University College of Medicine. Morgan.
Thank you very much, and it is certainly a privilege to join such an esteemed group today and to contribute to our understanding of how do we then develop community-centered approaches to addressing a narrative that is often overlooked and intentionally buried, and that is the opioid use disorder crisis in minority communities. I'm hoping today to share some lessons from the work we've been doing at Howard University around this very issue. Next slide. So today I'd like to highlight 4 aspects of a community-centered approach to addressing opioid problems in urban settings. And I think it centers around 4 ideas: community-centered data collection, community education and empowerment, developing an intervention that's community-centered, And finally, finding a way to have a sustained academic community partnership. Next slide. As my co-presenters have so astutely acknowledged, racism has penetrated even the system of healthcare and treatment when it comes to substance use disorder problems. In fact, the use of the word epidemic to refer to opioids was intentional, and it provided a frame of whiteness around this epidemic. It was a clear shift from an incarceration treatment modality to a healthcare treatment modality, from one of punitive approaches to treatment approaches. The rising Black death rate has largely been ignored in political narratives. And in fact, as Dr. Hansen mentioned, access to office-based treatments have unfortunately been isolated for the most part to white suburban areas. And those restrictive treatments and jail-based or prison treatments have been overutilized in poor Black populations. Next slide. In Washington, D.C., we work within a context that sadly is only contributing to this narrative that we're seeing nationwide, which is that in cities, the African-American population is suffering to a great degree from inequities in the substance use disorder treatment system. In Washington, D.C., our city is actually divided into political wards for voting purposes, but very interestingly, this also lines up with geographical zones of inequity, as I call it. So our work at Howard is primarily focused on wards 7 and 8. And if you look at those wards, they're actually divided by a river that runs through Washington, D.C. And individuals who live to the right of this major river are often facing inequities when it comes to food resources and housing. Greater than 90% of these individuals are African American, a third live below the poverty line. This zone is associated with the highest HIV prevalence rate. It's a mental health resource shortage area. And in fact, and sadly, it is the zone that is associated with the highest opioid overdose rate. So Howard University has become focused, next slide, on specifically clarifying the experiences of African-American residents of Ward 7 and 8 in Washington, D.C., who have a history of moderate to severe opioid use disorder, but have not been successfully engaged or retained in treatment and recovery services. And so in terms of the first goal, community-centered data collection, what does that look like? Our objective was to engage individuals with lived experience, neighbors, family members, and community leaders in the interview process. And in fact, initial community conversations were either individual interviews or small group meetings with faith leaders, mental health clinicians, community service providers, just to get a sense of how the community was experiencing the problem and how they envisioned the solution. One of the main lessons, and the first lesson I will highlight that came from this work, is that community members were actually not as concerned about treatment as they were about systemic solutions to structural violence. And when I say structural violence, what I mean is how societal forces have acted upon communities and individuals to create inequities. And so what we found is that as we completed our surveys and our interviews and our discussions with community members, many of them were more concerned about the economic disinvestment that to them formed a root cause of opioid problems. They actually wanted us as academicians to actually join efforts to lead in economic councils in the community and to help us link those discussions with community development and assisting with stopping the process of gentrification and oppression within Washington, D.C. So it was a very interesting lesson for us that, as one community board member stated, the community itself is the cure. And they challenged us with this idea of why do you feel that the only cure is medication? They wanted us to think about individual problems and behaviors as being a product of the disorder occurring within the community as a result of the forces acting upon that community in a rather violent manner. Next slide. We actually allowed and encouraged a community-centered vision and mission statement for our entire project. And so When the community wrote a vision statement, I thought this was really powerful, especially with its emphasis on freedom. So as they conceptualized it, the vision of the project, and we called it the Reach, Engage, and Retain project, is for wards 7 and 8 to be a healthy, thriving community. And again, an emphasis on needing a healthy structure before we can be healthy individuals, where residents experience freedom from problems with substance use and addiction. And again, the word freedom really spoke to me as the community highlighted the legacy and history of oppression, disinvestment, and marginalization. And they also decided on a mission that was not only to increase access to effective recovery and treatment services and to reduce stigma, but also to deal with root causes of healthy drug use. Next slide. I want to highlight a second lesson when it comes to community education and empowerment. As a larger objective, it was our goal to educate community champions and DC residents at large regarding key aspects of opioid treatment and recovery, and also to disseminate knowledge about treatment resources. However, what we learned is that the interview process itself was an opportunity to educate and empower the community. In fact, as we talked with our community advisory board, we learned that there were some blind spots even present within the board that we would need to answer and provide a response to. The board also let us know that minority community members were also subject to the political messaging around the opioid epidemic, that community members themselves, even those who were using heroin, did not associate heroin addiction with the opioid epidemic. So what we learned is that the use of the word opioid was often associated with prescription pain pills and classified as the white people's problem. This is how the community referred to it, themselves being subject to how this epidemic was presented in the media. Some community members did not even know that heroin was an opioid. So vital education was needed even during the interview process. So we developed supplemental materials for clearly listing the different types of opioids, including heroin and fentanyl, and clarifying the current toll on minority communities. And that in itself was an aspect of healing, because community members were able to reflect upon, wow, I actually did not realize that this epidemic that everyone is talking about and presenting as a white person's problem, a white community's problem, is actually occurring in my own community. Next slide. A third lesson that I will highlight is how did we develop a community-centered intervention. So again, we were caught between this tension of a community that really wanted us to deal with structural barriers and also having real, tangible needs and goals in regard to our research project. So how do we balance the need to communicate findings and seek feedback and apply revisions to a process that is also guided by the needs of community stakeholders? And we have walked that line and that tension, which we all face in academic medicine, of yes, we have to meet the goals of our and the parameters of our research funding, but the focus has to remain on the community. And how do we do that? We have focused at Howard on opening non-traditional doors to treatment, on allowing the community itself, which is one of the principles of community-based participatory research, to act in a way that is for its own healing and well-being, supporting the agency of community stakeholders. We have begun piloting an SBIRT, screening, brief intervention, referral to treatment, as a known framework within substance use disorder care. We have begun piloting an SBIRT intervention at a local church, which is within Ward 7 and 8. In fact, the pastor of that church has been instrumental in leading co-located mental health and substance use disorder services at his church. In fact, neighborhood commissioner meetings, political events also happen at that church. So it is known as a meeting space for the community. And so we are piloting an SBIRT intervention there, as well as at the DC Dream Center, which is a nonprofit community center, which has also been very active in our community engagement process. we are hoping to improve access through these non-traditional doors to treatment, through our brand new addiction medicine fellowship program, having our fellows actually rotate at these sites and provide substance use disorder care directly in the community. Again, a non-traditional door to treatment. Next slide. And finally, want to speak about an overarching goal of having a sustained process of community partnership. So the objective being to nurture relationships with our community advisors and partners that will guide long-term strategy and decision-making within our department. And so how do we do that? The community was very clear that they expected a sustainable approach to their involvement. They must feel valued beyond just the deliverables of a project. And so we have developed a strategy at Howard for utilizing and partnering with the Community Advisory Board as a liaison for all of our activities within the Department of Psychiatry. So it's not just delimited by a specific project or a specific grant or a specific research aim, but they are truly our partners in every aspect of our strategy within the Department of Psychiatry and within the College of Medicine. Final slide. So in summary, this is actually a word cloud of a lot of the issues that have been stated as we have completed our community engagement process. And notice that the emphasis is on people. The emphasis is on developing a healthy community for those individuals to live in. And so as a final challenge, I will just say that someone so astutely articulated in one of our interviews that the community is the cure. The community is the therapy. And I thought that was such a powerful approach for thinking about community-centered and community-derived solutions. Thank you.
Great. Morgan, thank you. And this is Karen Scott again, and thank you as well to Helena and Hansel. We will come to questions in a few minutes, and we've got some great interactions and questions coming into our Q&A box. But first, I want to turn to and reintroduce one of our board members, Dr. Westley Clark, who's a Dean's Executive Professor for Public Health at Santa Clara University. Dr. Clark is also a former director for the Center for Substance Abuse Treatment at SAMHSA. We're very appreciative of his time this afternoon and look forward to his comments.
Thank you, Karen. And I want to thank all of our presenters. They've done an excellent job of characterizing very complex subject and making reference to some of the disproportionate health and economic impacts that occur, particularly with COVID-19 and substance use disorders. Recognizing that structural racism is compounded by systemic inequities in the economy and in criminal justice. Really like Morgan Medlock's comments about the community being involved and dealing with what the community understands. If we don't reach out to the community and address the needs of the community, then what we have is a series of misunderstanding about some of these issues. Clearly, Hansel addressed community activity also by mobilizing trainees to enter the community to address complex issues, or reaching out by going into the community. I disagree with both Hansel and Helena on the barriers to buprenorphine treatment, in part because there are other medications that require special treatment. I just renewed my license in Massachusetts and in Maryland, and I had to do 50 hours of continuing medical education every 2 years to renew those licenses. So 8 hours of training to deal with buprenorphine and to deal with addiction issues is not an awful lot. So people invoke that, and I think more it's people don't want to deal with people who have substance use disorders. So physicians don't want to deal with it. And other evidence of that is roughly 50% of the physicians who get training who meet the criteria for a waiver don't go on to practice. So we're dealing with stigma and discrimination. Helena did focus on reverse racism, if you will, in terms of white people being targeted in the overdose deaths. Another complication of the overdose death issue that I think Morgan pointed to in terms of what the community understands is that we've forgotten stimulants, methamphetamine and cocaine, particularly cocaine in communities of color, but increasingly methamphetamine. The overdose deaths associated with methamphetamine has been increasing to the point where they represent a major component of overdose. And people who use psychoactive substances often mix them up. So we're seeing a combination of fentanyl and methamphetamine, or fentanyl and cocaine. Hansel mentioned George Floyd, and he's a good example. George Floyd's toxicology screen showed both methamphetamine and fentanyl. Now, as Carl Hart points out, the toxicology screens did not suggest a large dose of either one of those things contributing to Mr. Floyd's death. But the point is that we have to meet our community where it is. And overdose deaths are not just opioids, but also stimulants, and people are using these things. So Morgan's approach of getting the community to understand psychoactive substances and dealing with the issue of systemic, or some people call the triple pandemic, which is not just COVID-19, but also poverty / the economy and the hegemony of the criminal justice system. We wind up developing a culture of incarceration, and people start to accept that. So that gets you to Hansel's jail population, that the people accept that this is the price you pay to be in a society that marginalizes you and that excludes you. So our three presentations were very good, and as a board member of FORE, I'm really proud of our presenters and this opportunity to share this information to the general public. Thank you.
Wes, thank you so much for those comments and for joining us this afternoon. We will now turn to a Q&A discussion. Again, thank you to our audience. We've got a number of questions. We will get to as many as we can and encourage people to continue to submit as well. I'll say to all of our presenters, we have a number of kudos and great talks, which I'll echo for the terrific presentations from all of you. I'll lead off with a question to Dr. Hansen. A couple of related questions. How do you think the marketing and framing of buprenorphine as a form of MAT tailored to whites affects the attitudes and uptake among consumers of Black African-American background?
Thank you for that question. Well, I think it's a great question, but I expanded a little bit. I think that maybe what is implied here is that we have to take a closer look at why Blacks or African Americans aren't taking up medication for opioid use disorder in the same way. And let's see, I see in the question a question about marketing. So actually marketing is only one piece of the puzzle. And what I tried to do in a very brief presentation is paint a picture of multiple overlapping factors that have led to the really striking racial inequalities in medications for opioid use disorder, especially in looking at who is getting buprenorphine in the US, as a way of highlighting how another system in which these multiple levels, including the ways that neuroscience of addiction was invoked and addiction as a brain disease, including drug development, including marketing and media, including regulation, could be put together differently. I draw on the work of my colleagues in France, who have documented that, first of all, France has the highest rate of uptake of medications, both buprenorphine and methadone, for people with opioid use disorder in Europe. It also has a very low level of opioid overdose deaths. So at its peak in France in '95, they had 565 deaths from opioid overdose in a country of 60 million people. In the US, we look at that number twice and say, oh, you mean not 565,000 deaths? It's only 565 deaths. And there are many, many factors at play. Number one, they have, so just to take the uptake of buprenorphine there, they have a universal healthcare system. They also integrate harm reduction and social services, including housing and employment assistance, with medication for opioid use disorder in the form of community-based treatment and harm reduction centers, a network of them that are all funded by the state and make treatment free and are located in communities that are hard hit by opioid use disorder. Also, buprenorphine was introduced back in '96, not as a medication that was in a profit-based commercialized system of healthcare that was directed to insured consumers or consumers who could pay out of pocket. Rather, buprenorphine was introduced in France as an intervention for opioid overdose and HIV among largely non-white immigrants in the country in communities that were disproportionately immigrant and low income. So it was seen as a public health measure, and it was framed as part of a harm reduction approach. So those are just two of the factors, not to mention that direct-to-consumer advertising, direct-to-prescriber advertising in France are not legal, and Purdue Pharma, manufacturers of OxyContin, never got access to the French market because of a very strict review system for new drugs and their claims in the country, and very strict regulations preventing those with vested interests in the companies from participating in those decisions. So there are just multiple levels. But if we look at a system that has universal health care, combines treatment with harm reduction, as Hansel Tookes has very well described, locates services in communities, deliberately involves community members and activists in decision-making, which, by the way, recently has led to very rapid adjustments to their approach to medications and harm reduction supplies being disseminated to people in light of COVID-19. They've been much more effective than we have in quickly changing their regulations and getting people housed and getting harm reduction oriented policies in place in housing facilities where they tolerate a certain amount of drug use in order to keep people off the streets. All these things together in concert work to create a very different scenario in France than we have here. So I just want to point out that there are multiple levels of structural racism that have led to what we see now. And those have to be approached as a system, as opposed to one by one.
Great. Helena, thank you. Shad, I'm going to just ask you to follow on that as a second question that a number of people asked that directly relates. So before we move to the other presenters, which is, do you think that what you described as the technologies of whiteness could be leveraged for the reverse by anti-racist addiction providers to fight for equity?
Oh, what an interesting question. I have to read into that a little bit. So taking as the premise that whiteness is a driving force behind our pharma and biotech companies, because we're talking about a clientele that can afford those products based on a very strict economic racial hierarchy in the country. How could we turn that around? And that's my belief. That's why I have spent so much time developing this framework, because I think we have to really privilege the ideas about whiteness that are embedded in each of the structures that I just described as contributing to current inequalities. And so we are used to talking about racial inequalities in health in terms of quote unquote underserved populations in kind of a passive manner, as though we're just talking about people who haven't quite received the fruits or benefits of modern technology yet. And my task has been to illustrate, using the opioid epidemic, the opioid crisis, how it's not an accident, how it's actually quite an unexpected and predictable product of the forces of structural racism that drive our healthcare, pharmaceutical, and biotech industries. And in that, I'm building in a theory of racial capital, that actually our for-profit commercialized healthcare system in the US is not the only industry that's based on racial hierarchy, that's one of the driving mechanisms. So in order to make a real dent in that, we have to keep that in mind. We have to make it quite visible how whiteness plays a role, white power plays a role in that, images around whiteness, and especially how this hurts everyone, including whites. I think the opioid crisis really highlights that.
Great, thank you. Thank you. Hansel, I'll just direct the next one to start with you. Do we have any data yet or sense of the numbers of people who have been able to access medications, either buprenorphine or methadone, as a result of the temporarily relaxed rules under the public health emergency? And then even more so, do we know anything about a racial breakdown in that data?
You know, I'm not sure. I mean, we all know that that patients who are Black are much less likely to be prescribed buprenorphine. I do know that overall, just like after Hurricane Sandy, just like after Hurricane Maria, in general, access to treatment for opioid use disorder, access to treatment for HIV is much worse in a time of a disaster. And that's why it's so important for us to remain connected to our patients. And, you know, there's something very intimate about being home and doing these evaluations with patients in their own home, basically signaling that we're all in this together. But in general, I know that there was a movement for take homes from methadone clinics, but we have lots of reports in Miami of methadone clinics just closing. The same thing for substance use disorder treatment. People, a lot of the intensive outpatient programs shut down, and that's how actually we started serving a lot of people at our Tela MOUD clinic. And but I'm not sure actually about the accessing with the relaxed rules.
Great. Morgan, or any insight in terms of that? Any early data, sense of whether we're having an improvement in access based on the temporary prescribing and telehealth rules?
That's a very interesting question. You know, here at the Department of Behavioral Health, we are still actually analyzing whether the relaxed rules around prescribing have made a direct impact within our system. And currently it's actually unclear, and we are sort of awaiting a detailed assessment to kind of guide our advocacy around that on a national scale.
Right. And I'll share that we at the foundation as well are very interested in continuing to help to support and develop that database, that evidence base of what the impact is in terms of both quality, access and quality to services during this time. Let's see. Hansel, maybe you could add, there was a question about whether the state, whether the requirements you mentioned in terms of prior authorization, the extent to which they were Florida state specific versus CMS. Can you speak to that?
Yeah, so those are state specific. CMS was actually more permissive. Florida was, we had to show Florida what CMS had ruled and what SAMHSA had ruled in order to get them to loosen. For instance, we have every 3 months for patients who are on Medicaid, they have to do another prior authorization, just another barrier. So it's definitely dependent on the region. I will tell Dr. Clark, I know that you may not be in agreement with the X waiver as we are. I want you to know that everybody who graduates from med school at the University of Miami is being educated in harm reduction and will be buprenorphine waiver eligible. So that's definitely one of the things that we're doing.
We will make sure he knows. Thank you. Morgan, there are a couple of questions about the communities with whom you're working. So could you speak a little bit more about some of the barriers you faced when you started the work with the communities in DC? And there's also a question about in your community leadership groups, how many people and the individuals in those groups are people with an addiction or current users or past users of drugs themselves?
Sure. I'll start with the latter question, which is a bit easier to answer, and then I'll go back to the first. So, in terms of representation of people with lived experience, on our board itself, on our community board, there was 50% representation, and individuals who were either themselves participating in a buprenorphine practice, those who had recovered from opioid and cocaine addiction, as a mother. So that was a unique lens. And then we also had a young man, a young adult who was in recovery and had also experienced the lens of incarceration. So a very, very unique makeup of our board. And then the other members were made up of individuals from politics, from economic planning, from community organizing, and faith leaders. So our board itself was intended to have an eclectic representation, but with an emphasis on individuals with lived experience. And the same with our larger community interviews. Roughly maybe even 60% actually of those interviews and surveys and engagement initiatives included individuals with lived experience. In terms of the first question, what were the barriers? I'm going to emphasize the biggest one, which was building trust. And the first sort of our initial roundtable discussions, and we almost went on a tour through Ward 7 and 8. That's what it felt like, just trying to be sure we understood the experiences of that community. And of course, I'm a resident of Ward 8, and so certainly have some firsthand knowledge of that. But what I heard over and over again is this just another project? What's going to happen when the money runs out? What's going to happen when the project funding is not there? You know, where are you going to be when we're still left dealing with the larger structural issues that we feel actually are most important? So showing that what the community cared about would also be our project's mission was what was the biggest barrier. So I showed up in churches when pastors were discussing these issues. I showed up in meetings where the community was wrestling with racism and violence and police brutality. They would find me there right alongside them, interested, learning about the issues and speaking about those issues. So a lot of the work was done outside of the academic center, and to me, that was the most rewarding part, is building those relationships. So now here just this week, our team attended a community economic planning council, and so there we were as a team of psychiatrists and social workers, once again partnering with the community and showing that we were really interested in these larger structural issues that have to be addressed for the community to really be healthy and thriving.
That's great. I was so struck by how much the community went to the root causes and wanting to go beyond the just looking at access to treatment and recovery services. Hansel, there's a question. Could you speak a little bit more about some of the results for the IDEA exchange program overall? Some of your initial results in terms of an impact on getting people into treatment, overdoses, infectious disease changes?
Yeah, so as soon as we opened as the first legal syringe services program in Florida, we had a large task because we had to prove our effectiveness so that the program could be expanded statewide. That only took us 2 years to get the expansion authorized, and mostly it was because of the immediate decrease in the number of opioid caused deaths in Miami-Dade County. And that was at the same time that we were distributing thousands of boxes of nasal naloxone in the community, and really the first large street level distribution of naloxone down here. The same thing for HIV care, HIV testing and getting people into treatment. There was an HIV cluster investigation. We were able to get people on their meds and virologically suppressed. This is a community that was largely not in HIV care due to just horrific stigma within the healthcare system. And we have trained the staff at our public hospital in cultural competence and working with people with opioid use disorder. But in many ways, I've just seen that the healthcare system, the people who are there now, it's almost irrevocably broken. And that's why we're training the next generation of physicians to treat this community with kindness and compassion and respect. And also this movement towards taking the healthcare out of the healthcare system is really our path forward to an appropriate response to both the opioid and HIV epidemics.
Great, thank you. And this may be our last question. I'm going to ask each of you, maybe starting with Helena, and really to bring us back to what opportunities there are to learn and from current changes that everyone's trying to very rapidly adjust to under the constraints of the pandemic, and use that to inform later care. So the question was specifically around what you thought the best strategy is to convince the DEA to continue with COVID relaxed guidelines post-COVID. Those questioner says it's beyond egregious that the induction of MAT requirements present insurmountable barriers to underserved populations, such as the daily dosing for methadone observed urine analysis and discharge from missed appointments. Helena, can I ask you to start with any thoughts on how we move forward and maximize some opportunities around the relaxed guidelines right now?
Thank you for that question. It's really a pressing one. And I think you can predict one of my answers to that, which is we're in a unique period in US history where we're being forced to look at other countries for exemplars and styles of leadership that work better than our own for public health purposes. We're a very ethnocentric country in many ways, and we don't know very much about how other countries do their work of healthcare and public health interventions. So I already mentioned the example of France. And one thing that I didn't mention about the X waiver, which I know was extremely well intended at the time, is that the continued barriers to buprenorphine prescribing, including separate and optional training requirements rather than mainstreaming, for example, buprenorphine and other treatments for opioid use disorder and other addictive disorders into clinical training everywhere for all clinicians. One thing it does is it not only puts up barriers, but conveys that addiction is not a problem that all clinicians should be equipped to address. And in places like France, there's no separate training requirement because all clinicians are trained in the use of medications for opioid use disorder and other addictions. And it's an expectation that throughout the healthcare system, which is a universal healthcare system accessible to all, that addiction treatment would be available as a part of standard clinical practice. So that's one direction that we have to go in. And I think by using international comparison, we're going to learn a lot of things about how opioid use disorder fits in with COVID interventions. We know that promoting harm reduction along with treatment, alongside treatment, is really important. And that also implies ending criminalization of drug use. So really making it a public health mandate. And in the US, we've long separated harm reduction from treatment, clinical treatment, because they've been driven by very different kinds of people and political motives. And harm reduction has been relegated to activists that have largely, many of them people with lived experience who've been working against government resistance to harm reduction. And it's still true that in the US, in most states, there are bans on widely accepted forms of harm reduction, from syringe exchange to safe consumption facilities, with syringe exchange having tremendous evidence behind it and very little government funding or government coordination around those efforts. So if we can move towards, for example, integrating those things and privileging those with lived experience in the decision-making. That's a lesson that we can learn from the AIDS crisis of the 80s to 90s, that it was AIDS activism and the involvement of people who were directly affected, either HIV positive or taking care of HIV positive loved ones in decision-making at all levels, from how money is spent at state, city, federal levels to research agendas at the NIH. We have a lot to learn from those models and from international models. So I think we should be looking for people in places that are models in places that are much more successful than us, and also other health problems, public health problems, where there has been more success than around opioid use disorder.
Thank you. Hansel?
So I just completed a 10-year journey to bring syringe services to make them legal in the state of Florida. And I'm going to harness all the energy of all of those young medical students that I get to mentor. And I'm going to take them to Tallahassee so that we can work at least on a statewide level, making it so that everybody who graduates from medical school in the state of Florida is trained in prescribing these life-saving medications for opioid use disorder. But having been a student starting this fight and now faculty advising and mentoring students, I really do think harnessing the energy of the youth and their passion and their compassion, which is very different than some of the old school doctors, it's definitely our path forward, and should let everyone be a little bit more hopeful about what's to come.
Great. And Morgan, bring the question to you as well. So anything else that you'd like to add in terms of strategies, how we move forward, how we learn from this time of more relaxed guidelines?
Well, many are becoming aware of the emergency that our communities have lived in long before the beginning of coronavirus. We have been in a state of emergency since arriving on American soil. And so I think that this is a great opportunity for this focus and this emphasis on the emergent nature of racism and other structural issues for our communities to also finally benefit from an influx of resources. So I am also advocating for us to continue many of the revisions to our system that occurred during this pandemic. In terms of what we can do to make the case from a scientific perspective. Well, let's acknowledge, first of all, that our prior system did not necessarily result in excellent treatment retention rates. And so, and so why not try a low threshold model that meets people where they are, allows for any open door to be the correct door, and also utilizes non-traditional aspects of treatment. Thank you.
Great, thank you so much. Thank you to all. I want to, for all of our, for questions we did not get to, again, we will work with our presenters and up a Q&A document and have that posted as well. There are also a couple of questions asking about the foundation itself and grant funding programs. I encourage you to go to our website to about our approaches to grant making, and I encourage you to use to contact us through the website if you've got specific questions or ideas for projects. We're continually looking at the best opportunities that we can take up to use the resources of the foundation to further these issues and help develop solutions to them. I want to thank once more Helena, Hansel, Morgan, and Dr. Clark, who did have to drop off, but for really an incredible afternoon and set of discussions, and the work and the presentations and the work that you are doing, as I'm sure many of our participants are on the front lines every day, particularly during this time. Thank you all, and I hope that you will join us again in 2 weeks for our next webinar. Have a good afternoon and stay safe.